Welcome to Decoding Doctors' Evaluation and Management Documentation Guidelines Update presentation. In the next few minutes, we will walk through the essential information you need to code your dermatology office visits accurately, confidently, and at the highest appropriate level. Physicians and providers choose from 4 levels of service. Most dermatology claims fall within Level 3 or Level 4. A smaller number support Level 2. And Level 5 is rare. So today we will focus where your documentation makes the greatest impact. If you have questions about Level 5 or any other aspect of correct coding, our coding education portal is always available for you. There are common trends in coding, but it is your clear, individualized documentation that drives the correct level of service for every patient, every time. So let's begin breaking down the details and make sure you are fully equipped for the year ahead. Evaluation and management outpatient services can be coded by medical decision-making or by time. But both approaches still require basic clinical documentation. You need a history, an appropriate level of physical exam, and a clearly documented assessment and plan, not only for continuity of care, but also for medico-legal protection. By the time you have documented everything required for good patient care, you will often support a higher level of service with medical decision-making than with time alone. Medical decision-making includes 3 elements: problems, data, and management risk. But to determine the overall level of service, you only need 2 of these 3 to meet the requirements of a given level. A Level 2 requires 1 minor problem, a self-limited issue that would likely resolve even without professional care. Examples include a skin tag, an itchy bug bite, or a seborrheic keratosis that does not require treatment. Level 2 requires no data, and management risk is straightforward or none. Level 3s are routine in dermatology. They require more than 1 self-limited problem, or an acute, uncomplicated problem such as an actinic keratosis that is treated without biopsy, or a chronic problem that is stable, which means that it is at your treatment goal. A Level 3 may be supported by data when at least 2 diagnostic tests or outside notes are considered. If you or a derm pathologist in your practice is separately paid for interpreting a diagnostic test, you cannot count that same service again toward data. You also cannot unbundle a diagnostic panel to receive separate credit for individual components. If the patient brings outside test results and you review and analyze them, you may receive credit for that review. A medically necessary history from someone other than the patient also counts as data. Management risk for a Level 3 is low. Examples include sunscreen counseling or performing a minor procedure. A Level 4 is supported when the patient presents with an acute problem with systemic symptoms. For example, a COVID-related rash with shortness of breath, or a drug-induced exfoliative dermatitis with shaking and chills. More commonly, Level 4 is supported by 2 stable chronic conditions, or 1 chronic condition that is not at treatment goal. A new undiagnosed problem with uncertain prognosis may also support Level 4. For example, a neoplasm of unspecified behavior with a differential that includes skin cancer. A Level 4 may also be supported by data. Any combination of at least 3 tests, records, or notes may qualify. Credit may also be given for independently interpreting a test when you are not separately paid for that interpretation, or for discussing patient results with external physicians or providers. Management risk for a Level 4 is moderate. Examples include prescription drug management, minor surgery with additional risk factors, or social determinants of health that can prevent the patient from receiving recommended care, such as language barriers, transportation insecurity, or other difficulty. Let's walk through some examples. A patient presents with a cherry angioma and is reassured and sent home. This is a Level 2. A patient presents with a cherry angioma and nevi, receives sunscreen recommendations, and is sent home. This is a Level 3. A patient presents with neoplasms of unspecified behavior on the nose, back, and chest, with a differential that includes skin cancer. Biopsies are scheduled for next week. This is a Level 4. A patient presents with neoplasms of unspecified behavior on the nose and chest, with a differential that includes skin cancer. Biopsies are scheduled for next week. This is a Level 3. A patient presents with a neoplasm of unspecified behavior with concern for skin cancer. Biopsy was recommended but declined by the patient due to fear and mistrust related to prior healthcare experiences. This is a level 4. A patient presents for routine follow-up after excision and repair of a squamous cell carcinoma. The plan is to return in 1 year. This is a level 2. A patient presents with acne that is controlled and at goal while continuing prescription therapy. This is a level 3. A patient presents with acne that is not at goal and continues prescription therapy. This is a level 4. A patient with a history of 1 basal cell carcinoma, not documented as a chronic concern, receives sun avoidance counseling. This is a level 2. A patient with multiple recurrent basal cell carcinomas, documented as chronic concerns, is advised to continue SPF 50. This is a level 3. A patient with stable acne and psoriasis continues prescription treatment. This is a level 4. A patient referred for a lump is diagnosed with a cyst. A plan is made for extraction. This is a level 3. Let's wrap up with a few important compliance concepts. If the level of service depends on how the problem is classified, then who decides whether it is minor, acute, or chronic? You do, the documenting provider. A chronic problem is one you expect to last a year or longer. A stable problem has reached your documented treatment goal. An unstable problem has not. Your documentation makes that distinction clear. Auditors can only judge what they see in the note. Your note also needs to be completed and signed in a reasonable time. Auditors successfully argue that memory fades quickly. Timely sign-off keeps the record accurate. It protects your patients, and it protects you. Modifier 25 is used when a significant, separately identifiable evaluation and management service is performed on the same day as a minor procedure. In dermatology, this is common. About 60% of Medicare paid EM services include a minor surgical procedure on the same day, but it must be supported. An EM service should only be billed alongside a biopsy when you perform and clearly document a significant and separately identifiable evaluation and management service. If the visit focuses only on the pre- and post-operative work of a single lesion and no other conditions or concerns are addressed, a separate EM is not supported. With Medicare, Incident to billing is not allowed when the patient is new, or when an established patient presents with new medical complaints. The physician must have established the treatment plan the non-physician practitioner is following, and must remain involved in the patient's ongoing care. Direct supervision is required. Teaching physician rules apply whenever residents are involved in the evaluation and management of the patient. The teaching physician must be present during the key parts of the service. For time-based services, the teaching physician must be present for the entire duration. In most cases, in-person presence is required. The teaching physician must sign the note and must clearly document their participation. This presentation has covered key highlights of accurate EM coding, but it is not a complete guide. Be sure to review payer contracts and current CMS rules for full requirements.